Sevgili meslektaşlarım, sabahtan öğleye kadar olan oturumda Avrupa Karaciğer Pankreas Cerrahisi Derneği'nin organizasyonu, gelecekle ilgili düşünceleri, beklentileri ve daha sonra da HPB cerrahisinde ERAS'la ilgili konuşmalar üzerinde konuştuk, tartıştık. Şimdi öğleden sonraki bu oturumumuzda önce beslenme ve karaciğer ilişkisiyle ilgili konuşmayla başlayıp daha sonra pankreatitte beslenme konusunu ele alacağız. Önce karaciğer ve beslenme ilişkisiyle ilgili konuşmasını yapmak üzere Doktor Alper Uğuz'u ben kürsüye davet ediyorum. Buyurun.
Thank you very much, Mr. Chairman, dear presidents, dear guests and colleagues. Now this presentation session's topic is the nutrition and the liver. First of all, beginning, I have to say some couple of sentences about the functions of the liver. The major role of the liver is the regulation of the solutes in the blood that affects the vital organs and the important organs of the body. And then we have to keep in mind that all the blood comes from the intestinal system is passed through the must pass through the liver. And the storage and the metabolism of macronutrients, micronutrients, drugs and the toxins are the major functions of the liver. And it works as a factory of the body. The topic is two words, the liver and the nutrition. There's two sides of that. First off is the liver, I mean the liver diseases that we use in nutrition. And the other one is the nutrition that affects the liver. First part is the liver diseases and the nutrition. The liver diseases is a time schedule. We will say that chronic or acute diseases. Acute diseases is usually about the acute phase response, and we have to keep in mind and we have to manage that it's acute phase response without the fulminancy. The chronic liver disease is the important point associated with the nutrition because the malnutrition risk is high, especially in the advanced cirrhosis patients. In that patients, especially the patient is the alcohol abuser, the protein energy malnutrition prevalence is high, and the loss of body weight, loss of skeletal muscles, and there's a defect on the immunological system. And then we have to keep in mind the nutrition may restore the body mass in the stable metabolic conditions. If we think about the oral nutrition, I mean the oral intake, generally with liver diseases, generally patients with the liver diseases tolerate a normal diet. Sometimes restrictions will be harmful. Modified eating patterns like the 4 to 7 times small meals in a day, especially including at least one late evening meal, will help and improve nitrogen balance and substrate consumption. If there is a borderline protein intolerance for the patient, fiber-rich or vegetable-based proteins prevent hepatic encephalopathy. We have to keep in mind. And what about the oral supplements? I mean the nutrition supplements. Malnourished cirrhotic conditions who are unable to get enough nutritional requirements. The patients is SIP feeding help improvement of patients. It will 1.5 to 1 portion standard. Polymeric fulminase twice a day, 200 milliliter is a good choice. And that includes the low sodium. Intolerance of the high protein intake for the patient, we have to keep in mind we will use branched chain amino acid nutrition formulas to prevention of encephalopathy, and that will have a good effect on mental status and long-term good nitrogen balance and the liver function. What about the micronutrients? There is some conditions with the micronutrients, especially the patient is cholestatic or the alcohol abuser. The fat-soluble vitamins deficiency will improve the patient's position, and vitamin A and zinc, there will be a deficiency in that vitamin A and zinc, and we have to replace the vitamin A and zinc. That will have an indirect effect of the gustatory function of the patient. And the alcohol abusers will also have water-soluble vitamin deficiency, especially the thiamine, the B1. There will be an extra encephalopathy pathology, the Wernicke's encephalopathy, and we will have to discriminate it from the hepatic encephalopathy and the Wernicke's encephalopathy for the alcoholic abusers. And generally in the liver diseases, zinc and selenium we have to keep in mind as a micronutrient. And if there is osteopenia with the primary biliary cirrhosis, we have to add the estrogen to the supplements. And in that patients, the malnourished, the long-term chronic diseases, we have to keep in mind for the malnourished patients, refeeding syndrome. First reports come from the refeeding syndrome is Second World War, and the realimentation of severe malnourished patients, there is a risk of refeeding syndrome. It will change the patient's situation. The weight loss is 1 to 6 months, some positions, or that acute starvation over 7 days is a risk factor for refeeding syndrome. And the mortality of this syndrome is high because of the heart failure and neurologic complications such as comas and convulsions. What we have to do in that position? First of all, we have to keep in mind and we have to be aware of that position, and especially malnourished cirrhotic patients are at high risk. Alcohol abusers are especially at high risk. Be careful about the potassium, magnesium, and phosphor levels. And first of all, we have to check the serum blood levels of these electrolytes, and be aware rapid nutrition. Only the treatment of refeeding is to prevent the refeeding syndrome. So we have to first check the serum electrolyte levels, and then we have to keep away the patient's rapid nutrition. First, fluid and electrolyte balance have to be restored, and then with the zero fluid balance, and then we start slowly nutrition until 1 to 10 days, slowly, and then replace at the target level at the end of the 10th day. And enteral nutrition. Enteral nutrition in liver diseases, we usually do not use the enteral nutrition. We only use the oral intake, or maybe in bad situations, sometimes parenteral nutrition. But if we have to use the enteral nutrition, supplement enteral nutrition will improve the survival and the liver functions. Branched chain amino acids will enrich formulas beneficial, and nocturnal supplementation improves the nitrogen balance as like the other nutrition types. Tube feeding is controversial and usually do not use in liver diseases. Parenteral nutrition is a last resort choice. Branched chain amino acids enriched formulas will be used, and reduced aromatic and the other amino acids formulas reduce encephalopathy, but in the long term, no nutritional benefit and no survival benefit with the branched chain amino acid enriched formulas. MCT, olive oil, or fish oil are now a better choice than the soybean-based LCT emulsions, and it has a better leukocyte function and immune system functions. Routine preoperative parenteral nutrition, what we have to say about that? We, as our Indian institution, we do not use the routine parenteral nutrition in the pre-op patients. And it is not recommended for the SPAN, but cirrhosis and malnutrition is a high postoperative complication problem. But of course, we usually that patients the liver transplantation. Sometimes the situation is all the problem is treated. But if we have to do a HCC surgery, hepatocellular carcinoma surgery for a cirrhotic patient, pre and post-op nutrition superior to the crystalloid and the regular fluids, but we have no choice with the oral intake or enteral supplements. We have to give parenteral nutrition for the surgery of the HCC, but we have to keep in mind the refeeding syndrome and the electrolyte imbalance and the encephalopathy, keep in mind. And the cirrhosis, that is stable and replacement positions. There is only one thing I want to say. In the grade 1 and 2 hepatic encephalopathy, we can give protein products, amino acids to the patient. Only the grade 3 and 4 hepatic encephalopathy, there will be a restriction for the protein products. It is less than the other ones, and we will give branch chain amino acids to the patients. Post-op cirrhosis, early enteral nutrition will helpful to the patients. Now, the last part of the presentation. What about the effect of the nutrition to the liver? It is more important for the HPB surgeons because our patient group is not so chronic. We usually perform oncological patients, and then it's an acute procedure. And then we have to give nutrition to the patients because of the oncological effects and the gustatory functions. What about the nutrition and the effect to the liver? There's 3 situations. One of them is the steatohepatosis, and the other one is cholestatic liver disease, and the other one is Cholelithiasis and acalculous cholecystitis. Steatohepatosis is a frequent complication of totally parenteral nutrition, and biochemically, we find the levels of the liver transferase go up, and ultrasonographic findings are there is an enlargement of the liver, and the texture and the parenchyma of the liver will differentiate to a steatohepatosis. There will be a more frequent reason of that overfeeding, especially with the glucose. And if we treat or prevent the steatohepatosis, there can we use this cyclic administration. The cyclic administration, the steatohepatosis can be decreased by the administration of the overnight total parenteral nutrition by a pause during the day, and it will have a good effect. This situation is only for the totally parenteral nutrition, and we have to keep in mind, not the enteral and the other oral intake and the supplement nutritions. This is just for the totally parenteral nutrition. And decreasing the amount of the energy that we gave with the total parenteral nutrition, that reverses the effects on the liver and reverses the steatohepatosis. The cholestatic liver disease, it is a more severe complication of parenteral nutrition, and this part, the nutrition of effects are mostly come from the parenteral nutrition, and the cholestatic liver disease is a severe complication of parenteral nutrition, and it may progress to cirrhosis and liver failure if we cannot diagnose, and more frequent in children and neonatals. The clinical finding is the jaundice, and the biochemical findings are the high bilirubin levels and the gamma-glutamyl transferase and the ALP goes up. And the histology, there is a periportal inflammation, and if we are late to diagnose it, there may be a fibrosis to the liver, and it will be an irreversible situation in that patient. What about the etiology? There is multiple effects. There is multiple etiological factors on the cholestatic liver disease. First, we will say that the loss of enterohepatic cyclus, or the defect in the enterohepatic cyclus, and the bacterial overgrowth of intestinal system, and it will cause maybe a portal toxemia, lack of the antioxidants and the lipid metabolism, especially alpha tocopherol, and soybean derivative parenteral nutritions, and glucose overfeeding may be a position to de novo fatty acid synthesis in the liver. And what is the treatment? First, we have to keep in mind the parenteral nutrition and the effect to the liver in the long term. Hepatic dysfunction may also be prevented or reversed by oral or enteral prevention, enteral nutrition. And the prevention and treatment for the infection is another treatment option. And sometimes certain amino acids will helpful, especially taurine. And essential fatty acid replacement with lipid emulsions is important. In the treatment position, the two of things is the most important one, the oral and enteral nutrition, and essential fatty acid replacement is the important and the key point of that prevention and the treatment. Cholelithiasis and the acalculous cholecystitis is another situation that is about with the nutrition, especially the patients that are in the ICU units. Sometimes they made a consultation to the surgeon, and there's a patient situation that has a abdominal pain, and there is no gallstone in the ultrasonography, but there is a hydropic gallbladder and maybe some sludge in the gallbladder. The patient is usually an old patient and long-term in the ICU, and no enteral or nasogastric tube or another enteral approach feeding to the patient. The patient is usually a acalculous cholecystitis because of the gastric and the intestinal motility goes down. The trigger point is gallbladder motility, and after that the gallbladder he drops, and then there's an cholecystitis, and the mixture of the bile will change, and there is a sludge, and the other things go. Administration of cholecystokinin to stimulate gallbladder is a medical solution, but enteral nutrition has the same effect, I mean the equal effect, so enteral nutrition in the ICU patients will helpful, and treatment, early diagnose, minimal invasive approach when the inflammation starts, and the minimal invasive approach. But the prevention is the key point, and the enteral nutrition is the important point. Summary. As a summary, malnutrition is a common in chronic diseases, as like in liver. Restrictions sometimes not a good choice and harmful. The aim is to ensure sufficient energy and nitrogen and macronutrient statement balance. Parenteral nutrition in the long term has a worse effect on liver. Enteral nutrition is a better choice than the other ones. Thank you very much.
Evet, konuşmacımıza konuşması için teşekkür ediyoruz. Salondan soru ve katkı varsa alalım. Thank you for your presentation. Yes, please.
Thanks for the nice presentation. How do you assess the nutritional status of cirrhotic patient before doing transplant? I mean, do you use subjective measures or any lab data or any radiologic assessment? Which method do you use?
We usually use any of this because we have a living donor program. Before that situation, I mean, not so many malnourished patients, we usually treat the patient with the liver transplantation because we have a good choice at the living donors. But I think in the United States, I never worked there as a liver transplant surgeon, but for example, in the Korean patients, I worked there for 3 months. There is no so many malnourished patients I'm clinical looking to patient is malnourished or not.
Thank you.
I think the question was if you do any anthropometric measurements or albumin levels, pre-albumin levels.
Okay. Albumin and pre-albumin levels, we don't use it in cirrhotic patients because of the liver functions are not so proper. So maybe the anthropometric measurements or subjective global assessment may be a suitable situation.
Okay. Any other questions? Okay, let me ask you a question. If, let's say, we have a patient who underwent extended liver hepatectomy, for example, right resectionectomy. We have a very, barely, enough liver volume, and we, for some reason, we need to give a total parenteral nutrition. Then how would you manage this patient? Give for example, branch chain amino acids or these classic routine total parenteral nutrition solutions? How do you manage?
Okay. My first choice is not to give the parenteral nutrition to that patient because
sure,
it's a borderline
for some
patient.
Reason,
okay.
Let's say
first couple of days, I mean 1 to 5 days, I try to not to give the parenteral nutrition, but after the 5 days or 7 days, if the patient if the patient will not then approach to the oral or the enteral, we will give a parenteral nutrition step by step, not to give the full doses. I mean 30 milligram to the kilogram per day, not the full dose, maybe half. We will start, especially not only to give the glucose, first of all glucose in the first few days, and then give the multiple glucose and fatty acids and the amino acids. We will give both of them.
But we know also we well know that a good nutrition is very important. Just following such a large procedure, and we have a very small volume of liver. We need to enlarge the liver volume as soon as possible. Just we need to give it full. We need to cover all energy needs of the patient. So, but you said increase gradually the.
I mean the nutritional products, yes.
Okay. Do you use any enteral nutrition support during that phase? Or?
That kind of a patient is, I mean, the extended hepatic resection. We start the postoperative day 1 oral feeding.
Mm-hmm.
So
you don't use. Okay. You don't use any enteral supplement.
Parenterally, no, but enterally, yes.
Enteral, you use enteral nutrition.
First of all, not the supplement. Our idea is to give the normal food. I mean, sometimes the patients cannot tolerate the enteral nutrition products. I mean, the formulas. But in that patients, I mean, the hepatic resections. I mean, the isolated hepatic resections without any bowel resections. Postoperative day 1, we have to start the oral intake and then give the intake and make it up.
Okay. Any questions? Yes.
For the case that you said,
This patient can be a case of intestinal failure type 1, I mean a patient who has underwent a difficult operation with prolonged ilos. It's better to start TPN with at least 40 milligrams per kg per day energy, and there is no restriction.
Standard formula, right?
A standard formula, yes. Okay. And it's better to use small lipids instead of soybean in these cases. I mean, combination of olive, fish, MCT, and also soybean instead of long-chain fatty acids. And I'm not in agreement with doctor to decrease it, increase it gradually. I think we should start with high dose and continue it, just to help the patient for complete the regeneration process, I think.
Okay, let me then ask the whole audience. Is there anybody who tend to use a gradual increase of parenteral support, or anybody else who would like to advocate the high dose of total parenteral nutrition at the very beginning of postoperative period? Any?
You mean starting step by step, or starting with a high dose?
Yeah, Iranian colleagues say he would start at a high rate of total parenteral nutrition with a standard formula and continue that way. You said you adopt a gradual increase in the nutritional support. Just, I'm wondering if there are one. Yes, please.
I'm Mohsen Dehani, Professor of Pediatric Hepatology from Shiraz Transplant Center. I think this is the misunderstanding. Gradually increase calorie is used for severe malnourished patient for prevention of refeeding syndrome. But in normal patient, we can use the high calorie at the beginning of the feeding, just for prevention of refeeding syndrome in severe malnourished patient.
Yeah, but the scenario was not a refeeding syndrome. The case underwent an extended liver hepatectomy.
But the professor said gradually increase calorie for prevention of refeeding syndrome, I think.
No. The scenario is the remnant rival volume is in a borderline situation. So all the systems in the abdomen and the blood, the liver try to enlarge, okay?
In normal patient?
Yeah, in normal patient he said that. In normal,
yes.
Not a malnourished patient, he said that.
In normal patient we use the high calorie at first, as said Dr. Niku.
Okay. You work at the same clinic, right? At the same center?
Yes, same center.
Yeah, probably why?
Patients.
Okay. Any other questions or comments? No? Okay, thank you very much.
Thank you very much.